Hello, my name is Dr. Corey Richardson. I am the CEO and Clinical Director of Integrated Care of Greater Hickory and the ICGH treatment centers covering Western North Carolina. Today's topic is fighting the opioid crisis in our communities together. It is funded by the Cleveland and Lincoln Counties Rural Communities Opioid Response. I am also the HRSA Grant Program Director for this $1 million grant, and I'm very proud to be a lecturer at Northwest AHEC at the Wake Forest School of Medicine. I have no conflicts of interest to reveal, and the disclosures are already provided. Today's objectives are 5. We want to list the goals of the Cleveland and Lincoln County's rural communities opioid response. We want to appreciate the current status of the opioid crisis in the United States and its impact on rural communities. We want to describe the evidence, principles, and components of the collective impact and integrated care treatment model. And we want to summarize the key components of the community coalition model. And finally, we want to describe best practices in the treatment of OUD, including its importance with medication-assisted treatment providers and peer support specialists in treatment planning. So I am the recipient, along with Integrated Care of Greater Hickory, of a HRSA grant, and that is a $1 million federal grant over the 3-year period of the grant for Cleveland and Lincoln County. And these are our consortium members. And it's a lot like a collaborative or a coalition, but there's a lot of funding to our community interventions. And we want to offer a continuum of services and a network infrastructure and expansion approach to improve education, prevention, access to treatment, understanding of treatment, and we want to reduce stigma for SUD and OUD in our communities. The grant has 3 goals. 1, to increase the continuum of services from prevention to recovery by improving access and provision of services and resources. 2, we want to offer training and education like this talk today across stakeholder groups to improve knowledge and capacity for SUD-OUD change while emphasizing networking and system development to maximize communication, data sharing, and sustainability. And goal 3, we want to develop and expand the SUD-OUD workforce across stakeholder groups, including but not limited to professionals with Data 2000 waivers, such as PAs, nurse practitioners, MDs, and DOs. But we also want to increase the providers and other professionals at sites, such as screening sites, emergency intervention confidence, and REACH, such as naloxone distribution, and our peer support specialists. And we'll talk a little bit more about that later today. So there was an estimated 100,306 drug overdose deaths in the United States during the 12-month period ending in April 2021. And that's an increase of 28.5% from the 78,056 deaths during the same period the year before. So that's about more than 130. That means that more than 130 people die a day from opioid-related overdose. And a lot of times we do know that STOP Act from our governor here in North Carolina, and a lot of the interventions such as Rescue Narcan, fentanyl test strips, there was a real reduction in overdose deaths across the United States, particularly in some states, and even in North Carolina, a small decrease of overdose deaths overall prior to the pandemic. Subsequent to the pandemic, with the sometimes isolation, economic insecurities, closure of AA and NA and other types of support groups. A lot of addiction treatment providers were not able to change quickly enough into telehealth, and some really did not have the financial wherewithal to continue to deliver services while our payers were figuring out how to pay for telehealth. And so a lot of people lost their provider during that period of time. And so the drug overdose deaths increased dramatically. So we looked at the national statistics, and North Carolina mimicked those exactly the same way for the number of deaths during the 12-month period of the worst 12-month period of COVID. And many of us have heard this slogan before, the idea that addiction is a chronic brain disease. It is not a moral failing. And it was reiterated by the Surgeon General under the Obama administration, I believe. And so I want to bring that back again, is that we have made a lot of good strides in our communities to address stigma. And people are much more willing than they've ever been to seek help, but still we have a long way to go. And I believe, especially in our rural communities, we have a long way to go. This is a little bit older slide, but I still like the representation because it shows the synapse between the nerve endings there for our dopamine receptors. But we don't use terms like drugs of abuse anymore. We use substance use disorder. But I often will tell people this is a disease that happens between the ears. It is a brain disease. Drugs, such as addictive drugs and alcohol, do not affect those people with a substance use disorder the same way it affects other people. It hijacks the prefrontal cortex and the limbic system, and we all know the prefrontal cortex does math and helps us make good decisions. The limbic system is that emotional content that we have around our children and our lives. And somehow down deep, the mesolimbic system is that survival mechanism. Very often it's kind of called the reptilian brain because it's a very early part of brain development through evolution. And that's where drugs hit and sabotage and hijack. And so what it essentially does, it correlates. The brain kind of has not just chemical changes, but real structural changes. And the brain starts to interpret drug use as survival. For normal behavior, dopamine has a response in the brain, giving us a pleasurable feeling when it comes to food or sex or other activities that we really enjoy. But cocaine and opioids have a real strong dopaminic response. So strong that the body will auto-regulate, or what we call down-regulate. The body will stop making dopamine naturally related to other things that we usually find pleasurable, and it only has a response with opioids or cocaine. And we all know that heroin and fentanyl have a very powerful, even more powerful than a lot of other drugs, very powerful dopaminic response in the brain. And that's why people don't have drugs. They feel very despondent, almost suicidal. Sometimes they are suicidal, and they really feel like the only thing they can focus on is getting drugs. Here is the DSM-5 criteria for mild, moderate, and severe substance use disorder. And we're talking today primarily about opioid use disorder, and that includes obviously fentanyl, norfentanyl. And these are the different criteria. Are you taking the drug in larger amounts for a longer period of time than you intended? You want to cut down on it, but you're not able to. You're spending a lot of time obtaining the drug. You're craving or have a strong desire to use the drug. You're unable to carry out major obligations in your life. You continue to use even though you have a persistent recurring social or interpersonal problem that is caused directly by the drug or worsened by the drug. Stopping and reducing very important situations in your life, such as work or family events, or even taking care of your children. Recurrent use in physically hazardous situations, kind of like falling, passing out behind the wheel. And then consistent use despite acknowledgement of all the difficulties. Two of the cardinal traits that we usually see with addiction are going to be tolerance and withdrawal. Tolerance, it takes more and more of the drug to get the same effect, or the same drug over time does not have the same effect. And then withdrawal, when you don't have the drug, you get sick. Our clinicians do very extensive clinical assessments, and these comprehensive clinical assessments often include what's called an ASAM level for us to decide what level of care a person with a substance use disorder needs to go. So if you look at these different dimensions that are considered, the person's acute intoxication or withdrawal potential coming off of the drug. Dimension 2, biomedical conditions and complications such as untreated diabetes, hepatitis. Dimension 3, emotional, behavioral, cognitive problems. Or they have untreated schizophrenia? Do they have a history of trauma, which would challenge and make the treatment planning more difficult and reaching their outcomes, the treatment outcomes more difficult? Dimension 4, readiness to change, exploring individuals' readiness and interest in changing, and that would mean somebody realizes that they need help versus maybe somebody that's being forced to come to stay out of jail. And motivation is very important in trying to create appropriate treatment plan. Dimension 5, relapse, continued use, or continued problem potential. And that means how many times have they worked on this problem and tried to correct it. If somebody has repeatedly relapsed or completely failed treatment several times, they may need a higher level of care than somebody that maybe is coming in, they still have their job, and this is the very first time that they've ever tried treatment. And dimension 6, the living environment, the recovery environment. Are there people actively using the home? Are they sleeping under a tent, under a bridge, or in a tent? Or do they have a very strong, stable family life? Nobody uses in the home. There's no alcohol in the home. So it kind of helps us to figure out where placement should be. When you look at those 6 dimensions, you're going to be able to better understand what level of care. And so it might be early intervention or outpatient, 0.5 to 1. It might be intensive outpatient at 2.1 or 2.3, or it might be 2.5 partial hospitalization. It might be all the way up to 4.0 medically managed intensive inpatient services. So that's detox. And one of the key elements of this is, and why sometimes people do fail, is that we generally will throw people into detox and then no aftercare. Or we give them some detox and maybe 30 to 90 days in inpatient and still no aftercare. So really trying to step people down from detox to maybe residential inpatient to partial hospitalization, 5 days a week, 4 hours a day, or intensive outpatient, 3 hours a week, 3 days a week, 3 hours a day. Really would help us as we transition them from outpatient and then ending treatment, but continuing with some life changes and some good drug-free coping skills so they can maintain their recovery. So that's the idea when you're creating a treatment plan, and it helps you place them initially looking at the 6 dimensions previously. So if we understand as providers that addiction is a disease, and we understand we need a good assessment to understand the best level of care, and we want to incorporate really an integrated treatment plan, a biopsychosocial and even spiritual plan that really holistically embraces that person and their needs. Why are we still struggling with 100,000 overdoses every year? Why have we not gotten better? And the reason I feel is that while we could use more quality care from treatment providers, providers are just one part of the overall picture. And so this is a model from Project Lazarus, and this kind of model has been used for collaboratives and coalitions before. And but I think it's a very good model when it comes to the opioid use disorder crisis that we're having and the overdose crisis that we're having. We need to look at, do we have harm reduction in our community? Is there appropriate pain management support in our community? Are we controlling diversion? Are hospitals and EDs working closely with other providers in the community? Is there provider education like today about diagnosing, treating, or referring? Is that being done? Are we prescribing opioids too much? And I think that for North Carolina, we have identified that as being an issue, and I think we're doing much better with queries, for controlled substances. Pharmacists are reviewing those, doctors are reviewing those, and PAs, etc., prior to prescriptions and then at refills. What about community education about stigma, prevention, disease of addiction? And so if you added all those together and continually, evaluated it, improved public awareness, I think this kind of a model for a community, not just addiction treatment providers, we'd have better outcomes for our communities. In the grant, Lincoln County and Cleveland County both have community coalitions. They're strong coalitions. Both of those coalitions are deeply embedded with those stakeholders, from the health department to law enforcement to EMS. And so the funding that we have for both these counties really does support the work throughout the coalition and with individual stakeholders. What are some key components with proven effectiveness for coalitions? So community activation and coalition building, monitoring and surveillance of community data, prevention of overdoses, such as rescue Narcan, fentanyl test strips, etc., education, anti-stigma communications, media, use of rescue medication, as I just mentioned, and of course we want to evaluate our project components. So there's a key component there, and this is true for both of the coalitions in our counties. And the collective impact model. So with collective impact, it really is a 5-condition approach to solving complex societal problems using effective communication between and alignment of the partner organizations. So the collective impact approach has been used by governments and nonprofits alike to create really measurable improvements in people's lives. You have a common agenda, you have a shared measurement system between agencies, and you have mutually reinforcing activities. So one isn't fighting against the other, and you can see very often that this might happen in certain communities, whether it be the faith community versus law enforcement versus EMS and maybe the recovery community. We need to make sure we're all on the same page. Continuous communication in these coalitions. And of course, there needs to be a backbone support organization. And with our coalitions, I think they really do have some backbone support organizations that have really allowed our coalitions to grow. In our own work in Catawba County, some of the outreach I did through our coalition has been with churches and civic organizations. A big part, I think, that may be missing it when we look at coalition work in our rural communities. ICGH has really been strong on community awareness events. We are very visible. You'll see some of this here with huge forums in Catawba County, lighting up the courthouse for overdose awareness. In Lincoln County, that's us there at the front. And speaking out to Rotary clubs and other civic organizations. And then, of course, real strong events like pill takebacks and others. Just doing a lot of work. We have done that work in the Apple Festival, in Oktoberfest, and others, where we're able to really talk to people individually who are challenged by a lot of our community interventions or challenged by MAT, and then just give them some really fundamental knowledge about treatment and community interventions. Very proud of this billboard here. You'll see this billboard across Lincoln and Cleveland County, and ones like it. We are funding that through our grant. This was actually done with both United Ways, both health departments, and of course myself, with help from an expert from the federal government on anti-stigma campaigns. And so really destigmatizing addiction allows people in the community, I think really it changes their idea. If we looked at addiction like we would cancer or diabetes, it would be easier for many in the community to come forward and seek help. And what kind of outcomes we have then for our community? Our foster homes are filled already. Our jails are filled. And so I think it would be really important. And so that's been a big part of coalition work. And we do that with our outreach. We do that with billboards and media and Facebook ads. So coalitions are always supported, as I showed you earlier, provider education, kind of like the talk that we're doing today. I've been very honored to work with Wake Forest School of Medicine at Northwest AHEC to create these talks about best practices, the integrated care model, MAT, over the last, I think, 7 to 10 years. I can't remember when we started, but it's been an honor. And so specifically around the opioid crisis, specifically around proper prescribing and pain management, around diagnosing and treating addiction. And so therefore, offering that in our rural communities, maybe even increasing the number of MAT providers, or at least improving our referrals to MAT providers, I think is key to making a difference in the opioid crisis. Of course, research is needed. I think there's been an amazing amount of research in addiction over the last 10 to 20 years. Probably a lot of it is due to the opioid crisis. It has been lacking prior to that. This is some research that I did in North Carolina for treatment readiness and physician assistance in a state monitoring program with substance use disorder. But the importance of research so that we can improve evidence-based models of care is essential. From research, we know that certain tools work better than others in treating individuals, identifying them, doing brief interventions for those who are early in the stages of addiction, and then referral to treatment, as well as some not just screening tools, but also diagnostic tools. And here's just a few right now: the audit, the DAST, the DSM-5, which we reviewed earlier, and a few other ones. The CAGE questionnaire is a really short tool. The opioid risk tool really does talk a lot about risk of overdose. If this person's on other drugs like benzodiazepines or mental health medications, the risk may be higher of overdose. And then the high risk criteria. If prescribing a narcotic or other addictive substance may lead to a substance use disorder, asking certain types of historical questions, patient-specific questions, you may be able to gauge if this person should have a narcotic or other types of addictive substances like a benzodiazepine or a stimulant. They may be much more apt to become addicted. So these are really good provider tools, but are people using them prior to prescribing? So this is the North Carolina Controlled Substances Query. It's PMP aware. PAs, nurse practitioners, physicians who are prescribing controlled substances should use it prior to the initial prescription, as well as any refills. It covers the entire state. It does help us to understand if a patient is using multiple providers for the same narcotic or the same controlled substance, or if they are using substances that they should not use together, such as a benzo with a powerful narcotic. Unfortunately, a lot of times these queries across the country are just in a state when a lot of people are going across state lines to get some of their prescriptions. More and more we see states cooperating so that these queries, these portals for looking up patients' recent prescriptions cross state lines. ICGH and coalitions are doing a lot of substance use prevention, influencing such as legislation and policy, changing organizational practices, fostering coalitions and networks, kind of like what we've talked about today, educating providers, promoting community education, and strengthening individuals' knowledge and skills. One of the prevention programs in Cleveland County for fifth graders, the grant is currently funding. And ICGH has often offered prevention talks to elementary schools and middle schools. If you are waiting to talk to your children in high school, you've probably waited too long. Most of the people that we're seeing that are coming into our program started using at a very young age. Over the last 10 years, harm reduction has been a very contentious topic. Initially, when we talked about rescue Narcan, and even sometimes today, people feel that rescue Narcan is part of somebody's drug use, that they're only using it so they can continue to use higher and higher levels. It is an opportunity to talk to somebody after you've rescued them from a near overdose about getting help. Harm reduction also includes stuff like pill takebacks, getting those medicine cabinets emptied. Fentanyl test strips is testing the drug you're about to use, determine what it is before you use it. Norfentanyl and some other powerful opiates, people are dying before they even get the needle out of the arm or the straw out of the nose. It's very, very powerful. Same with clean needles. People have a real physiological, kind of psychological problem. I think it's a visceral problem with clean needle exchanges. While it does prevent HIV and hepatitis, I will tell you that these types of community interventions give us an opportunity to talk to people directly to see if they want to change their life. It is not, at least in Lincoln and Cleveland County, just really promoting safe drug use. I will often tell people, and we will say it in our coalitions, that the safest drug use when it comes to heroin or other drugs isn't going to get your kids back. And so, but we do want to keep people alive until we can get them help. But we use harm reduction in everyday life, don't we? Whether it's a helmet or a speed limit, whether it's sunscreen or a seatbelt, filters on cigarettes, or even age limits on alcohol, tobacco. So I kind of want to put it in that perspective. There are a lot of things that we could just not do. I know that my diet could be much, much better. But sometimes we do some things for harm reduction's sake. And be open to the real evidence that harm reduction does move people into treatment and treatment can move people into long-term recovery. One of the misconceptions that we mentioned is that harm reduction enables illicit drug use. That's not true. There is illicit drug use. Harm reduction does not condone illicit drug use. We've mentioned that. There may be programs that look at harm reduction differently, but in Lincoln and Cleveland County, and at least with our counties where we offer harm reduction, it really is about moving people into the concepts of treatment and recovery or living a life without drugs. And another concept is not in my backyard attitude, that the fear of harm reduction programs will increase substance use and crime in the surrounding communities. Although this fear is not supported at all by research. But we want to make sure that there are misconceptions, and I think a lot of that's just associated with the stigma of addiction. And here are some well-known harm reduction interventions. This is Rescue Narcan. It comes in any of these. It could be a nasal spray, an naloxone injection. The North Carolina Harm Reduction will give this out for free. We give it out as well in both counties to people who could benefit from it if there's active use in the home. And we do train people how to use it. And statewide, you do not need a prescription to have this. You can go into any pharmacy and request it. The pharmacy will charge you money, where our nonprofits or our coalitions will not charge you for the use. And here is a medicine locking device. Why would you use one of these? To keep medicine away from children and others who need it, who would want to use it. So they come in devices like this where you put the pill bottles in it and lock it with you can use a key. You can use some pill bottles themselves, have a locking cap. So there are a lot of different ways you could use this to lock meds up so children especially don't get into it. And even those kind of a bank bag looking, it's used really impossible to cut through with a little key lock, just to keep medicine away from children primarily. We also don't want you to keep narcotics and other controlled substances in your medicine cabinet. If people break into your home, that's generally where they go to steal medications. I was the chairperson of Project Lazarus of Greater Hickory, and we did pill take backs at several locations. So we would do pill take back events to get unused medications out of your medicine cabinet and dispose of them. And we also had drop boxes with all of our law enforcement offices. You'll find that true in Lincoln and Cleveland County as well. And also disposable pouches, so you can throw your medication into the pouch and zip it up, and now it will destroy it so nobody else can use it. And this is another real good community intervention to reduce the incidences of overdoses. Safer use, clean needles, alcohol pads, etc. While we do not want people to use, we do not want them to also get HIV or hepatitis and have to treat that, or endocarditis. People die from endocarditis every day, and so making use safer while they are contemplating getting treatment is one of the concepts of harm reduction. Fentanyl chest strips, which I mentioned earlier, so that people know exactly what they're using. Very often people think they're using heroin, but they're using illicit fentanyl that's created generally in these machines in the backs of trucks that are easy to move around. The concentrations widely vary, and so people easily could overuse and die. Clean needle exchanges, just like safer use kits, allow us to give clean needles that do not spread disease. Hepatitis, bacterial endocarditis, HIV, very expensive to treat, sometimes life-threatening when it comes to endocarditis. And so what we want to do is keep people as safe and as healthy as possible until they're ready to start treatment, until they are ready for whatever treatment that fits their life. And this is one of the ways that we can do that. And people are much more likely to enter treatment if they get the opportunity to talk to somebody during one of these exchanges. A big advancement has been in our ERs and hospitals. Our emergency medical services no longer just rescue somebody and put them out the door. Very often this is an opportunity to engage somebody that nearly died from an overdose, get them help immediately. In one of our counties where we work, there's a bridge MAT program, so they are given MAT at the time of the rescue. They connect with a peer support there with the opioid response team, and then they are immediately referred to a provider, given the opportunity to change. And so rather than just give them somebody's card and say, hey, you can call them, it's a way, you got much better chances that they follow through with treatment. Some of the biggest changes that I've seen has been within law enforcement. Diversion programs like LEAD, law enforcement assisted diversion, allow people who with minor crimes like shoplifting, rather than go to jail, are told to go to treatment. They're taken directly to the case manager, but if they don't follow through with treatment, they have a case pending. Also recovery court, jail services. We provide services inside the jail like peer support. Recovery court means that their participation with treatment allows them to get done with probation and parole maybe quickly. And so we got the pre-adjudication as well as the post-adjudication issues. And this grant specifically not only offers peer support inside of the jail, upon release, our peer supports are there to help them with the resources, treatment, housing, and other needs that they have. I mentioned briefly about a Bridge MAT program with the Community Response Support Team. This is an opportunity that emergency services, along with law enforcement and peer support, can work with those that are struggling with addiction to give them stable housing, transportation, and other services, get them into treatment, and then move them into long-term recovery. As we mentioned about the Bridge MAT program, which we hope that we'll be able to start in possibly both Lincoln and Cleveland County. ICGH is currently doing this in another treatment program that we have in Iredell County. It allows us to start them immediately there at the site of overdose, near overdose death, on Suboxone, which not only takes care of craving and withdrawal, it is a blocker, so it has a real protective factor if they reuse. It allows individuals to focus more on their employment, their housing, and their family. Suboxone has a very low potential for misuse and reduces the spread of infectious disease as well as violent crime statistically. You have much higher treatment rates when MAT is used, and as much as 59% less likely to die from an opioid use disorder, and that's that protective factor that I was talking about. A provider like me will partner with EMS and others in like law enforcement so that we'll be able to immediately respond to those needs and get them into treatment. Our peer supports have been very essential with working the peer supports that are hired directly by EMS. They partner, and really one of the fundamental concepts we were talking about earlier is in any coalition or any partnership is that communication piece so that we can have better case management. In my own work in Western North Carolina and throughout the state, been very honored to work with Tom Tillis's office, Patrick McHenry directly, Governor Cooper directly, trying to really affect change with national policies, state law, federal legislature, administrative law, specifically about funding things that work, and then really tapping down on prescribing that really was driving the opioid crisis. So I'm really honored both sides of the aisle, been able to work with our lawmakers, and I do authentically believe that they want what's best for our community, and they've been able to help us with funding on the state and the federal level. One of the most exciting initiatives that we have seen in North Carolina is the North Carolina Certified Peer Support Specialist Program. ICGH and all of our treatment centers are run by persons in recovery, long-term recovery, and so there is lived experience while they also have really strong clinical skills. Peer support specialist, the profession itself is based upon that lived experience. We train peer support specialists as part of this grant. We have taken people from each county and been able to train them to make them peer supports. We have placed peer supports inside of DSS, inside of the jail, and inside of shelters. it has been very remarkable about case management and engagement with people that are struggling. One of our peer supports goes out with crime prevention. They use a thermal drone to find persons that are homeless, are unhoused, and unsheltered. And they also go out with the shelters, and we have done amazing work with our peers by bringing them supplies, necessities such as socks and underwear, menstruation products, and then been able to talk to them about the proper use of harm reduction while we give them that as well if that's something that they're interested in, and we talk to them about working with the peer support specialist. Even if they're not interested in treatment, but just somebody that they can talk to who might connect them with resources when the barriers start to fall down. There does seem to be more openness about possibly going into treatment, and therefore that's when we've even provided some support for transitional housing in both counties through this federal grant, and the peer supports have been essential through a social model of running transitional housing programs in both counties as part of this grant. So rather than just tell you peer supports have lived experience, let me give you a little better definition. I guess I put the cart before the horse. Peer support specialists are people living in recovery with mental illness and or substance use disorder, and who provide support to others who can benefit from their lived experiences. The North Carolina Certified Peer Support Specialist Program provides acknowledgement that the peer has met a set of requirements necessary to provide support to individuals with mental health or substance use disorder, and sometimes both. Like our own emergency department hospitalization program, some real strong research has demonstrated improved outcomes with using peer support rather than the same interventions without peer support. As mentioned, peer supports have been essential in our unhoused populations, those unsheltered persons as well, not just those in the shelter, but some of those that are in these encampments that are growing and moving throughout both our rural counties and throughout rural counties in the United States. Those who are justice involved, those who end up in DSS, and other governmental agencies and nonprofit. One of the hopes that we have is those peer supports that we have placed throughout agencies in both counties are going to demonstrate such improvements in case management and outcomes that those agencies will want to keep a peer support full-time on staff. And that's one of the most important parts of our grant effort is sustainability, is that when the grant is over, we want to, everything that we're working for, we'll be able to sustain in both counties. As you remember, the integrated treatment model for opioid use disorder, it was very important about addiction providers in that little wheel. It was one of the spokes on that wheel. Behavioral interventions are probably the key component of any treatment plan when it comes to an opioid use disorder, and it is supported by medication-assisted treatment, identification of physical problems, and getting that treatment as well, psychiatric issues, and treatment of all comorbidities. Case management, which I sometimes call care management, and that means the housing piece, the employment piece, the transportation piece, education piece, all those others, as well as the social interventions, and that's really strongly in the recovery community and the peer support community, surrounding people with really good influences as they're trying to do all the work in early treatment. This slide really does sum up completely how we look at treatment planning at ICGH and how quality treatment planning should be approached. I created it for the governor at an opioid panel that we sat on with him in 2018 here in Hickory, North Carolina. You see clearly the principles that need to be stigma-free and person-centered and peer-supported. One of the things I like about it is community-based, and of course the features. You got to have a shared treatment plan, shared definitions of terms, shared diagnosis, and not working against each other when it comes to these treatment plans. Because we do use a combination of providers in every treatment plan. We use the medical piece from PAs and MDs and DOs, along with our counselors, and that would be on the psychological piece. and our groups and our individual therapy, and it's very recovery oriented. And then, of course, the social interventions from, it might be the recovery community, it might be peer support. And as you look at this slide a little bit more clearly, and if you request this slide deck, I'll definitely send it to you. This is a nice way of making sure that you have identified all the problems and issues that may happen with any clinical assessment, with evaluating any person coming for treatment, and making sure that those are met. And you can see where a model like this would work very closely as a treatment provider, why you would need to have real good relationships with community stakeholders, and housing and transportation and pharmacy services and the MCO. So who are the providers on an addiction treatment team? And it will be a number of different, and I usually say this alphabet soup. The LCAS is licensed clinical addiction specialist, licensed clinical social worker, licensed clinical mental health counselor, we used to call LPC, licensed marriage and family therapist, psychologists or psychological associates, the fee-based practicing pastoral counselors, certified peer support specialists, certified substance use disorder counselors. In North Carolina, we call it a certified alcohol and drug counselor. Psychiatrists or psychiatric providers, family practice providers, board certified addiction medicine physicians, nurse managers and specialists and coordinators and case managers, toxicologists and pharmacists. So a lot of people work together to make sure that treatment planning is appropriate and that our patients, our clients, can reach their treatment goals. What are some of the differences in the medications that are used and who uses them? So you have an office-based opioid agonist, antagonist, medication-assisted treatment. And so the Data 2000 waiver was focused on what we call OBOTs, office-based opioid treatment. That's going to be our buprenorphine products. They're going to be sublingual or injectable or implantable products. They have no appreciable side effects when taken appropriately. Naloxone in combination with those products prevent misuse, such as injection or inhalation. There is special packaging to prevent accidental overdose or use on children, and it also reduces diversion, as the special packaging have numbers on them so you can track them from the person that was prescribed to the person that ended up with them. There is some mild overdose risk with alcohol and benzodiazepines, so a lot of providers may not prescribe if alcohol or benzos are on board with that patient, or they may reduce the dosage for that individual. And then, of course, they have special X-waiver training that we'll talk a little bit more about so that you can prescribe Suboxone in a clinic-based setting. And there is a ceiling effect. So usually we say that anything more than 16 milligrams or 2 8 milligram strips or tablets, it's probably not going to have any appreciable effect whatsoever. Every now and then we do know that with really powerful opiates, maybe something for a brief period of time over that 16 milligrams might be needed, but a lot of times anything over 2 strips or 2 tablets is probably going to be shared or borrowed rather than used. So I did want to mention that now methadone clinics, quote unquote, OTP, opioid treatment programs, do now offer Suboxone alongside of the option of methadone. This is an office-based, non-addictive opioid antagonist, so you don't need any special training for Vivitrol or Revia. It's just naltrexone. The Revia is the oral tablet, and Vivitrol is the monthly injection. And it's simply a blocker. It's an antagonist. There is no special waiver to use this. It's only a blocker. It does work for up to a month when you use it by injection. You want to make sure that there have been no opiates on board that patient from 7 to 14 days prior to induction. Sometimes providers will give an oral dose just to make sure, because sometimes patients may not want to admit that they have used an opiate and they think they'll be fine. But if you give Revia or naltrexone in general with somebody who has opiates on board, they're going to go into precipitated withdrawal. The same is true, of course, of Suboxone. You really do need to have somebody that's going into withdrawal a little bit prior to the first dose, and then you would do induction, which is a slowly increased dosage, not the full dose immediately, And a lot of this is covered in the X-Waiver training if you wish to either be a Suboxone provider or you wish to have the training so that you'll understand better about referrals to other MAT providers. So one of the important aspects of today's talk is to address the need for more MAT providers in our rural communities. It has been identified as a real need to address the crisis. Sometimes there may be bias in practitioners against substance use disorder, people that struggle with it. There may be a perception of added liability if you write MAT, or there is even the possibility that you would feel that your clinic would change or your practice would change by increasing the number of people who visibly do struggle with a substance use disorder. Data 2000 was written specifically OBOT, office-based opioid treatment, for providers in a clinic like a primary care center or OB-GYN, and a lot of other providers as well. Maybe it's an emergency doctor who could give a 7-day script like in a bridge MAT program and then refer to an addiction treatment provider. It could also be, like I said, a primary care provider who wants to add a counselor in their setting or work tightly with another counselor or refer to a drug and alcohol treatment program like ours. And so that being said, I hope that some of the conversation today has opened your mind to possibly becoming MAT waivered or buprenorphine waivered. X-waivered is what it's called with the DEA. Qualified practitioners can offer buprenorphine and medication approved by the FDA for the treatment of opiate use disorders. To receive a practitioner waiver to administer, dispense, and prescribe buprenorphine, practitioners must notify SAMHSA's Center for Substance Abuse Treatment, the Division of Pharmacologic Therapies, for their intent to practice in this form of medication-assisted treatment. Meaning, if you were going to use naloxone or Vivitrol, you would not need to file any special form. The notification of intent, or NOI, or buprenorphine waiver application must be submitted to SAMHSA before the initial dispensing or prescribing of OUD treatment medication. Qualified practitioners do include the following, except for clinical nurse specialists in North Carolina. So we have physicians, nurse practitioners, PAs, certified registered nurse anesthetist, and certified nurse midwives. But in North Carolina, that does not include the clinical nurse specialists. Now, there have some recent practice guideline changes that have allowed for an alternative to the notice of intent for those seeking to treat up to 30 patients. So the customary NOI requires eligible providers to undertake the required training activities prior to their application to prescribe. The alternative type of NOI allows those providers who wish to treat up to 30 patients to forego the training requirement, as well as certification to counseling and other ancillary services. So those practitioners utilizing this training exemption are limited to treating no more than 30 at any one time. Time spent practicing under this exemption will not qualify the practitioner for a higher patient limit. This exemption applies only to the prescription of Schedule 3, 4, and 5 drugs or combinations of such drugs covered by under the CSA. So the idea, if you go through this process and you get the extension, that won't allow you to go up to 100. If you go through the training and you do the NOI, you can do the 30 for the first year, and then you can move up to the 100 after you have experience incorporating counseling and other interventions. So it's really only the training is it's not very burdensome whatsoever. So if you take the training, these qualified practitioners who undertake the training can treat up to 100 patients using buprenorphine in the first year if they possess a waiver under 21 USC and meet certain conditions. So while some may take the training and just stick with 30, under certain conditions you can move prior to that first year to 100 patients. One of the two conditions must be satisfied for qualified practitioners to treat 100 patients in their first year. Number one, the physician holds board certification in addiction medicine or addiction psychiatry by the American Board of Preventive Medicine or American Board of Psychiatry and Neurology. Or two, the practitioner provides medication-assisted treatment in a qualified practice setting. A qualified practice setting is a practice setting that provides professional coverage for patient medical emergencies during hours when the practitioner's practice is closed, provides access to case management for services for patients, including referral and follow-up services for programs that provide or financially support the provision of services such as medical, behavioral, social, housing, employment, educational, or other related services. And this is most addiction treatment providers. Most programs do all of these things, such as our own. So the practitioner provides medication assisted in the qualified practice setting. In such a setting, uses health information technology systems such as electronic health records, is registered for their state's prescription drug monitoring, such as PMP Aware, North Carolina. And they also accept third-party payments for costs in providing health services, including written billing, credit, collections, policies, and procedures, or other federal health benefits. So those are very specific qualifications that have to be met. Some of the other qualifications I would like to mention to you, the charts have to have a specific locking mechanism. So if it's an EHR, there might be 2 passwords. If it's a paper chart, there has to be at least 2 locks, maybe a locking cabinet in a locked room. There has to be a review of the query monthly for every patient that's in the program. And they do want you generally to watch the numbers and be able to document month to month the number of patients that you're seeing. So after that 1 year at the 100 patient limit, the qualifying practitioners who meet the above criteria can apply to increase their patient limit to 275. For those providers who wish to treat more than 30 after their first year, SAMHSA does the fund of provider clinical support system to provide practitioner training in the evidence-based prevention and treatment of OUD and offers required trainings needed to apply for buprenorphine waivers. So a lot of the trainings, as stated here, are just free of charge. For anyone taking on Suboxone and adding this MAT, a lot of these billing codes probably already look very familiar to you already. The 99204, the 99214, the modifiers as needed, also urine drug testing. And so keep in mind that treating people, quality treatment, still has to have remuneration, and we offer specifically anybody who has some billing challenges, whether it's one of the private insurances, Medicare, Medicaid. ICGH is going to offer a biller who has 30 years of experience to work with your team to make sure that you're getting paid, even the modifier for telehealth services. So if you have any of those challenges, we're really willing to help you in a rural community such as Lincoln or Cleveland County become an MAT provider. We want to make sure that anybody that is given MAT also has behavioral health interventions, and these are the codes that are being used for behavioral health interventions. Many MAT providers will want to partner with somebody outside of their own program, or they may wish to hire somebody inside their program, either full-time or part-time, possibly a contract basis, so that medication-assisted treatment gets the most benefit when it's really married to behavioral health services. For our program, most people will titrate off medication and continue in treatment until they're finally discharged, or they close treatment, terminate treatment, and continue into long-term recovery. So we really want to make sure you understand Data 2000 requires it. The STOP Act and state laws require the use of behavioral health interventions, not just MAT alone. And of course, here are some more of our billing codes for our urine drug screens or other screening mechanisms, counseling as well, and group settings. And so anybody that is starting MAT and you're having challenges with billing, we want to be able to support you and making sure you're getting paid for the services you're providing to your patients. Here's a quick POTS test. Do you know these answers? Approximately how many people die from overdose daily in the United States? DSM-5, can you name 5 criteria of the 11 that we talked about for OUD today? Do you remember what SBIRT stands for? Is that something that you could use in your practice? Do you remember what it stands for? Give an example of SUD-related screening or diagnostic tool. Give one example of an ASAM level of care and the number it was appropriate with. And then what is a peer support specialist? There's 6 quick questions for post-test. And I know everyone knew these. There are more than 130 people die a day from opioid-related drug overdose deaths. And that's just opioids. That's not just overdoses. Those are just opioid-related overdoses. Our powerful stimulants are now causing overdose as well. DSM-5, tolerance, withdrawal, craving, unable to take care of regular activities of life, etc. I think you remember those, DSM-5. And you'll get very comfortable those who become MAT providers, so you can decide if it's mild, moderate, or severe opioid use disorder. SBIRT is screening, brief intervention, and referral to treatment. Some of the screening tools might be the AUD or the DAST, or a diagnostic tool like DSM-5. Simple ASAM level, and you could probably be able to treat this level in your own outpatient setting, would be a 1.0. If you felt like they needed a higher level of care, you might do 2.1 for intensive outpatient. But if they came in with alcohol and benzos and opiates, and you're afraid that they stop those medications, they might die from DTs or seizures, you might need a medical detox at 4.0. A person with lived experience is a peer support specialist. They have lived experience with addiction, they're currently in recovery, and they have specific training to offer social support. These are the references that I used to create the talk today. And finally, are there any questions? Please, if there are any questions, how I can improve this talk, update this talk, give this again to your agency or your clinic directly, either live or through a webinar, feel free to just email me at crichardson@integratedcarehickory.com. Would love to talk to you. I'm very responsive to emails. And here's our contact information. Here are the locations that we currently have in Western North Carolina. Some of our social media, which includes Day One Recovery Housing, Integrated Care of Greater Hickory, which is now on Facebook as ICGH Treatment Centers. Want to really thank you for participating in today's educational webinar, and please reach out to us for any more information about our programs or any of our other educational opportunities, all free of charge. Supported by the Health Resources and Services Administration of the Department of Health and Human Services as part of an award totaling $1 million with 0% financed with the non-governmental sources. The contents are those of the author and do not necessarily represent the official views of nor any endorsement by HRSA, HHS, or the U.S. government. Recipients are required to use this language when issuing statements, press releases, requests for proposals, bids, solicitations, and other HRSA-supported publications and forms describing projects or programs funded in whole or in part with HRSA funding. Example of HRSA-supported publications include, but are not limited to, manuals, toolkits, resources, guides, case studies, and issues briefs. And again, thank you very much for being part of the webinar today.